Just a small note, Lilian, if anyone opened the mic after being admitted, just mute him until the slides finish, because I will not have access on the participants list.
Good evening to all doctors, nurses who join us today for our meeting, Lisa Caster Sharing Experience. My name is Lilian Farak. I am KZ Business Unit Manager in United Arab Emirates. Today we will have two interactive sessions for Lisa Caster Sharing Experience, followed by question and answers. To proceed further, I would like to invite Dr. Monica Koshal for the first lecture. Dr. Monica doesn't need any introduction, but as a small brief for Dr. Monica has diploma in neonatology from UK and fellowship from the Royal College of Pediatric and Child Health in UK, master in pediatric from India. Dr. Monica currently working as head of the Department of Neonatology in Emirates Hospital in Dubai Healthcare City, and also head of the Department of Neonatology in Iranian Hospital in Dubai. She has a lot of publication in neonatal and international journals. Dr. Monica, the mic is yours.
Thank you very much. Thank you for the kind invite. And before, I don't want to waste time, and we'll just start our session. I will just talk about the LISA as such, evidence-based, and some clinical real life experiences. So how do we do it? And if any questions in between, you guys will be free to ask at the end of the lecture, and in between also there is no issues that we can talk about it. So if you talk about the methods of surfactant delivery, there have been a lot of changes, and if you see from the conventional method where we were giving surfactant with a bolus, where one dose or multiple doses were being given, to a continuous infusion, and then came the insure, and then in-recture, which means intubation, recruitment and surfactant giving, and then extubation. To that, we move to unconventional newer modes of giving surfactant, where we are also giving intraamniotic instillation before the baby is born, pharyngeal instillation before baby takes the first breath, and instillation within 72 hours by LMA, and then the LISA mist using aerosolized nebulized surfactant. So my basically would be only on the LISA, and the different methods of the LISA are were by the different people. It is a colon method where the 4 to 5 French feeding tube is used, Hobart method where 16G angiocath is used, and then take care method where 5 French feeding tube is used, but no Megel forceps is used. In colon method, the Megel forceps was used. And then Karolinska method where catheter and 5 French feeding tube with no Megel forceps, and Sonshore method where 4G feeding tube was used with Megel forceps. So if you talk about colon method, because that's the one which came first in 2007 in Germany, where they used a thin catheter and they used Megel forceps because it's very fragile. And the main concept was that you are using it on a spontaneous breathing infant, and then several centers across Germany started it. And 2011, they came up with the results of AMV, which is avoidance of mechanical ventilation by surfactant administration trial, and they thought they decreased mechanical ventilation. And then Hobart method came because I know everyone can think of that Megel forceps is very harsh on babies, and so they came up with a semi-rigid vesicular catheter without the Megel forceps, and again it was administered to a spontaneous breathing, and it is called MIST. So this AMV trials and the other trials, outcomes were different in these trials, and they some of them were showing as primary outcome as intubation, and the others were BPD. And the main big trial, which is going on for a very small baby, NINSAP trial, the results are still pending. This Take Care trial, where they compared Ensure versus MIST, and they found that MIST did reduce intubation within 72 hours, and CPAP and mechanical ventilation was less. And also, not only that, the BPD was less, 10% versus 20. And then came the systematic review, which included 6 RCTs, and it showed the similar kind of results, that it decreased BPD bed or death, mechanical ventilation. And they concluded that this is a very good method to reduce BPD and mechanical ventilation. And the studies included were these. And the composite outcome, if you look, death and BPD combined, was quite less. If you can see the diamond going much away from the central line. Only BPD was reduced. And mechanical ventilation anytime during NICU admission was reduced. Need for mechanical ventilation within 72 hours was reduced. And if you see only death, that was not significant. So it came up like a good systematic review in favor of LISA. But unanswered questions are, if we are using it, when should we use it? Which baby we should use it? Are we okay with the FiO2 of 30 or 40? And nowadays we are talking of, this is not a good method, and we are talking of going for lung ultrasound to decide on which baby should be receiving surfactant. That's a different topic in itself. And then the procedure, like why we are here, that you need to have training, and without people getting trained and doing it, we cannot compare. And what device we are using is very important, which one should be used. We are using off-label devices, medical devices like angiocath and all that stuff. So that's another issue. Laryngoscopy technique, because video laryngoscope would make it quite easier. And pre-medication, which I will be talking in detail, and dose and preparation, which will not cause too much of reflux and will cause good benefit. So the newer studies are 2, which we are waiting for the results, Optimist A trial and a SANE trial, which are looking into these minor details which are not looked into earlier, which catheter to be used in babies less than 32 weeks, and how much dose to be used. And we'll wait for that trial's results. Now, the different devices used for LISAs are many, and you can see the NG tube. Some of the people, one of my colleagues used ET tube number 2, and then the angiocath, and then this is a LISA catheter. We'll talk about that in detail. So different people used a different kind of catheters. So, and they used different ways with or without Megill forceps. Now, if you talk about problems with the LISA, one of the most important problem is failure to insert the catheter to the vocal cords at first attempt. And especially if it is more flexible kind of a catheter, it becomes all the more difficult. Second problem which we face is significant surfactant reflux. And how do we find out if there is a reflux or not? When the baby is not improving when you give surfactant, when you see literally the surfactant coming out, or you recover the surfactant from the gastric aspirates. And the other issues are sometimes when we are doing the LISA and we are giving, and which we also see even when we give the surfactant through the ET tube, the baby may desaturate, may go bradycardic because there is an obstruction. And there may be a need for positive pressure ventilation in 10 to 30% of the babies. What they found is it's not LISA or insure or intubation and thing. The moment you put a laryngoscope in, the nurse have seen that the cerebral blood flow has difference and saturation is different. And also there might be an issue with a focal rate of increased rate of focal intestinal perforation. And this is especially seen if the baby is too small. And they have attributed it to the CPAP given along with the LISA. And then when we are using a feeding tubes, what may happen is there may be perforation at the tip of the feeding tube, and this may lead to the reflux via the upper perforation, or a unilateral surfactant deposition when inserted too deep. Now, when you want to, if you have a big NG tube and you want to shorten it to go to a right depth, what it may cause is mucosal injury and bleeding by creating a sharp edges. And then because of the reflux, the surfactant received might be quite less than what you really want to give. There may be a chance of dislodgement of the catheter. And then with the more fragile tubes like NG tube and all, you will need a Megill forceps. And when you will use a Megill forceps to prevent the dislodgement and to go it right, then you will take more time. You may cause more trauma. Baby may be agitated, and there may be a CPAP leak. So when you see that, we get a question, is LISA really less invasive? So is it a way to avoid positive pressure ventilation, but still it requires intubation? Is it easier? So I would say that you need to have intubation skills. You should undergo a training as you are giving a baby, intubating a spontaneous breathing baby. So it needs a gentle procedure. It depends on who performs the procedure, which catheter you are using, and how are you securing your airway. So let's talk of one by one. Now, intubation leads to discomfort, pain, and distress. So do we need analgesia and sedation? So if you see the pros and cons of LISA, you are intubating an awake baby. You are causing pain. You may increase IVH. You may lead a surfactant loss. You may take time to intubate. The good point is it's a spontaneous breathing baby. You're not intubating. You're avoiding positive pressure ventilation. But easier it is when you are really knowing how to do it. Now, I want to stress on pain and stress the LISA can cause. So it's not the LISA which is causing pain and stress. It is the laryngoscope which is causing pain and stress. And this paper came where it showed a physiological effect of laryngoscopy if you're not giving analgesia and sedation. The moment you're putting a laryngoscope in, it is actually stimulating a very hyperreflexic area, which will cause a release of norepinephrine from the adrenal glands and prolactin from the pituitary glands and cause immediate tachycardia and hypertension. And this is physiology, but if we look at the papers, it also showed that if you sedate the baby during LISA versus when you're not sedating the baby, it does have a big difference in the comfort news score between the two groups. Another study by the same group in 2019, Decker et al., they again studied, and what they found was in a sedated babies, the comfort news score group was much better in 76% of the sedated babies compared to 22% of the non-sedated babies. However, when you sedate these babies, it may cause increased incidence of DSATs, and you may require a positive pressure ventilation. So you should know how much to sedate and with what to sedate. Another proof of concept that when they used fentanyl analgesia, it didn't cause much of the apneas or cardiovascular instability. And a bigger trial is awaited for this. It is a Termet-Strauss trial, which is undergoing for stress assessment with and without analgesia during surfactant therapy in preterm infants. And this will give us a better data. Till then, the position statement, what we have is pre-medication for ET tube in newborns. Because the physiological effect is there because of the laryngoscopy, so we should be doing pre-medication until and unless we are doing in an emergency situation. So American Academy of Pediatrics and consensus of European neonatologists say that you should do analgesia and sedation in combination of both. So what do we use here is pre-medication with atropine 0.02 milligram plus fentanyl 2 microgram per kg. And at the same time, we load them with the caffeine. We don't use propofol. What about surfactant loss? So many studies have shown that when you do a LISA with a small catheter, it has, and especially flexible catheter, first, it has a fails in intubation, 18% versus only 10%. And there is a visible surfactant. Someone wants to ask something? And there is a visible surfactant regurgitation. So can we avoid this by LISA catheter? Another study which compared the ET tube size 2.53 with the orogastric tube which was used for administering surfactant through LISA. And they found that orogastric tube had lot of surfactant loss. And the temperature different did not make a difference in the surfactant loss. And the phospholipids were lost the most, which are the most important ones. So what are the factors responsible for surfactant loss? Thin tube with inner diameter 2 to 3 times lower than the ET tube is the main factor for surfactant loss. Proteolipid mixture with high density has a high resistance to its passage, which increases when you put through a thinner tube. Different plastic material has different adherence property. Length of the tube may also matter. Temperature has no effect on this. And something which may help may be air bolus. Now, do you need to adjust the dose because of this surfactant loss? And can we prevent this surfactant loss by this LISA catheter because of the different material it is used, the size which is different? This is to be seen. Then difficulty in intubation, which all of us must have faced. And there are studies which show that the failed intubation 18% versus 10%, and these were when we were using NG tubes. Now, can we avoid this by using a stiffer tube like a LISA catheter? Now, the different catheters which are used are feeding tube inserted with Magel forceps, feeding tube without Magel forceps, 13 centimeter angiocath, 30 centimeter angiography catheter, umbilical catheter affixed to a stellate, and ET tube. So there was a study and they found that the rigid catheters would, like this is a rigid catheter because you have put a UVC with the stellate and endotracheal tube. They have a lesser duration to intubate, whether it's done by the neonatal intubation trainer or ALS baby trainer. Both had lesser time for intubation when you use a rigid plate thing. And neonatologists felt much easier to use either a ET tube or UVC with stellate. So which is a more stiffer thing. And then 5-country Manichaean study found that neonatologists preferred using the LISA cath rather than angiocath for less invasive surfactant administration. Then there were different surveys and outcomes. A European survey showed that 32% of the cities were using LISA and 87% were using NG tube, 26% were using semi-rigid catheters. And the people who were not using LISA, this was in 2015, reasons given were lack of familiarity of the procedure. So here we are here to get rid of this problem. They felt that discomfort to the baby is there in 26%. So that is definitely there. So you should give sedation and analgesia. 22% thought there's no benefit, and 13% felt there was no evidence-based method, and 7% had never heard of LISA. Then another later European survey was there, and they found that LISA is increasing in some of the centers, and the techniques they were using were all mixed. Feeding tube in 56%, vascular catheter in 34%, suction catheter in 15%, and they were mostly using the routine dose of surfactant. So the reasons for them, they were mostly using for 26 to 28 weeker babies, not the smaller ones. And the reason they were saying they did not use which was not used in 41% of the NICUs, because they didn't have experience. So they all need experience. They were missing consensus on when and how to perform LISA. And 89% of them thought that if they would learn, they will definitely do this LISA technique. And adverse outcomes were same: tracheal surfactant reflux, bradycardia, hypoxia, need for intubation, unilateral surfactant deposition, mucosal bleeding. And then in US, always US is different from the Europe. So there were very less people who were using in US, and some of them have not even 84% were not using LISA. And this is 2000 and survey 2019. I was very surprised, but most of them said that if they get to learn the technique, they will be definitely using it. What is our unit of experience of LISA? In 2000, we were using in Zulekha, but I joined Emirates Hospital in 2017, September. So I will be talking of experience of in Emirates Hospital. So we did, and in 2018, when our unit started functioning properly, we gave surfactant through LISA in 15 of these babies, and we used feeding tube in 10 and umbilical catheter in 5. 2019, we could get hold of LISA catheter, and 16 surfactants were given. Feeding tube was used in 5, ET tube number 2, umbilical catheter in 2, and LISA catheter 7. And then to 2020, we had 18 babies with LISA, and we used LISA catheter in 8 of them. The other things used were feeding tube, ET tube number 2, and umbilical catheters. In 2021, we have already given surfactant through LISA to 8 babies, and all of them received with LISA catheter. And if I tell my experience, our nurses and our registrars, they don't want to use any other thing other than the LISA catheter. It's so easy, so quick. And we are using sedation and analgesia, and baby is quite comfortable with that. And hence, this is our practice. Only sometimes it's out of when we don't get it, or if it is costlier, because cost is an issue, that's the time we don't use it. Otherwise, we prefer doing that. I would like to talk about, because this is new thing which is coming up, leaks around the CPAP with LISA. So just because we know when we are intubating, there is no leak, and when we are putting LISA, there is a leak around. And so the caution came in this paper where they found that the CPAP leak is happening during LISA procedure because catheters are too narrow and they are less stiffer. They cannot be provided ventilation with them, and the peak pressure leaks occur in vivo. 40 to 50% delivered pressure is lost, and especially when your mouth is open. And if surfactant is delivered by thin catheter with closing mouth, risk of pressure leak is reduced. So that's what we try, that we close the mouth. And there were studies when they said that if smaller the catheter, more leaking would be happening. And then there was another study which also showed that CPAP transmission was less when we were using LISA. So how to overcome all these problems? So if we have a short apnea, hypoxia, and bradycardia, how do we handle it? We should slow down the injection speed, interrupting the surfactant administration, or if needed, by a couple of manual breaths via CPAP device. That is, in our experience, should stay in place during the LISA procedure. So this is important. And we should use more rigid catheter. That's what we are doing, LISA catheter. And appropriate length should be used, a little bigger catheter. So you should not be using 4 French. And higher dose can be tried, which we don't do usually, but early second dose can be an alternative. Always try to keep the mouth closed after you have put the catheter in, then close the mouth when you're giving the surfactant. And air flush after surfactant. This was a paper by one of my colleague, Karthikeyan. Syringe air flush technique eliminates surfactant reflux as a limiting factor in using higher dose. So he found that when he used Curosuf in 9 of the babies and Surfactant in 4 of the babies, and success was there when he used a air flush. Then he found that the regurgitation of surfactant was not happening. So now let's talk about the procedure. So a physician experienced in surfactant administration should administer the surfactant. You should warm the surfactant prior to administration for 8 minutes if the vial is held between the palm of the hands, or for 20 minutes if you just keep it at the room temperature. The vial should not be heated and it should not be kept over the radiant warmer to hurry it up. And if you are keeping in the room temperature, don't keep it more than 30 minutes because it will increase the viscosity. Do not shake the surfactant. Ensure that CPAP circuits and the fixation of tubings over the scalp is adequate and snugly fitting. LISA catheter size should be chosen in the same way as ET plus, that is 6 plus weight. And if you're using 5 French feeding tube, you have to cut it. And you should now be making sure it should not cause trauma and pain and later problems. To make it more rigid, you can put it in the freezer, or you can use a stellate, or you can use a ET size number 2. A direct laryngoscopy should be used, And under that, you can use whatever Lisa catheter, feeding tube, ET size tube, but we are using Lisa catheter now. And you should see that the moment you're putting the tip, it should go just 1 centimeter beyond the vocal cords. And laryngoscope would be taken out and the catheter would be stabilized. This is important, on the side of the mouth. If you don't stabilize it, it may come out. And during the procedure, do not interrupt the CPAP, keep the mouth closed, and infant should be connected to the pulse oximeter. Preductal and oxygen saturation and heart rate should be monitored throughout the procedure. A timer is very important. It should be started at the time of insertion of laryngoscope blade. Administer the surfactant over 30 to 60 seconds through the feeding tube after taking out the laryngoscope and closing the mouth. Timer should be stopped once the catheter is taken out. So you should know what time did you take. And believe me, after we started using the Lisa catheter, the time taken to do all this has come down drastically. During the procedure of administration, if there is a bradycardia, that is heart rate is going below 100 or SATs go below 80%, then the feeding tube should, or the Lisa catheter should be taken out. CPAP should be continued. In case of apnea, you should go for bag and mask ventilation. We are doing TPs. And so we should reinitiate the surfactant administration after we stabilize the baby back to the CPAP. And the same procedure can be repeated. And the remaining, the surfactant, what is left, can be given. But if you have failed 3 attempts of catheterization or 3 subsequent positive pressure ventilation is required, you have to abandon the procedure and you have to go for proper intubation. All the time, you have to maintain strict asepsis throughout the procedure. In case there is a visible regurgitation of surfactant in the mouth, procedure would be withheld, and check the laryngoscope if you are in a right position or not. And the baby should be stabilized first during such each regurgitation and choking, and then another attempt of Lisa should be done. If during the checked laryngoscope catheter is found in the trachea and vitals of the baby are stable, continue to administer surfactant in the same attempt. But in case visible surfactant in the oral cavity is there and you feel there is a inadequate administration as denoted by no decrease in FiO2 requirement, baby is still meeting the criteria of surfactant, that then we should always try and give surfactant within 2 hours, because that means we might have regurgitated. So this is one of the video which I would like to share, how to give surfactant by thin catheter. So we are putting a laryngoscope in, and CPAP you can see is there on the baby, and we are not removing the CPAP, and we are going to be seeing the larynx well. And then this is the one which is, because you are not using a Lisa catheter, you are using a feeding tube. So you have to use a Magil forceps, which I just don't like, because I think it is very, very this thing for the baby. So with the Magil forceps, the feeding tube is being inserted, and it is, see how difficult it is becoming, because it's bending and it's taking time for us to go in, even when we are using the Magil forceps. But finally, we are going in, and we will be going in till 1 centimeter inside the vocal cord. And once we are therein, we will remove the laryngoscope, and we will make sure that we are fixing, otherwise it will come out. And then we will slowly give the surfactant, and we will see if we need the FiO2 more than what it was required earlier. We will keep an eye on the monitors, and we are going to be installing it slowly to see if there is any reflux happening. So this is before the Lisa catheters were used. This is with the Magil forceps, and this is with the Lisa catheter, with the feeding tube. And you can see all the time the CPAP is not taken away. CPAP is there, and all the surrounding is sheets are there which are sterile, so that we don't want any infections to go to the baby. Because if we do any kind of procedure and we give infection, then that's not a good way to do it. And see, because this is a Surfactant and not a Curosurf, so it's a high dose which is being required to be given to the baby, and so it is taking a longer time to go in. And if we use Curosurf, the beauty is that we may not require that much of the dose, and it will be easier and faster for us to deliver the surfactant. But this is how the procedure is, looks very simple, and this is how slowly we have to be monitoring the baby throughout the procedure. And once we have given, and now you see the air bolus is given, so that whatever surfactant is there, it should go all inside, and then slowly we are going to take the tube out. So the procedure is done, and then the other way to give surfactant is through the laryngeal mask airway. And whenever you are using a laryngeal mask airway, you are not actually using your laryngoscope, so that problem with the laryngoscope is not there. And so you can position the LMA, instill the surfactant in 2 to 4 aliquots via the LMA, and each aliquot usually followed by brief IPPV until surfactant disappears from the LMA. And this is what usually we are using the LMA only when we are not able to intubate the baby, because there is a problem with the airway. And but now the people have started talking about, because it's less invasive than using a laryngoscope. So there are studies which are going on to give surfactant with the LMA and not with the intubating. And smaller LMAs are also coming into thing, and there are people who are making smaller LMA also. And we happen to use this Lisa catheter and Curosurf with the LMA, because we had a baby Beckwith-Whitman syndrome whom we could not intubate. And actually we put an LMA, and we gave surfactant through the Lisa catheter. And the baby was actually ventilated with the LMA for 2 days, and 2 to 3 days actually. So I will show you. This is our published video. It is SARSA, that is surfactant administration through the laryngeal mask airway. So today we are going to use a new technique for our unit for a baby with a Beckwith-Whitman syndrome who has macroglossia, micrograntia, and a very difficult kind of an airway. So we will be using LMA for managing the airway, and we will use SARSA to give the surfactant. And the SARSA is a surfactant administration through laryngeal supraglottic airway. So we have to keep things ready, and for that we need a proper sized LMA, the surfactant. The Lisa catheter, why we want to use this is because we don't want something to kink inside when we are giving surfactant, and we want it to go freely. So we are going to use a ET holder to hold the LMA. And also we need a CO2 detector, because when we are putting an LMA, we have to be sure that it is going and delivering to the lungs. So the CO2 detector will give us a confidence that it's in a right position.
We have one baby preterm with the features suggestive of Beckwith-Widman syndrome. As the baby has difficult airway, so we have inserted laryngeal mask airway because of macroglossia and difficulty in intubation at the time of resuscitation. Because baby is preterm and having respiratory distress, so we are giving surfactant through a new technique, which is SARSA technique, surfactant administration through laryngeal supraglottic airway. This is relatively a new technique, and we are trying in our baby. As you can see, baby is with the LMA and carbon dioxide detector is changing color, which means LMA is at proper position. So the next step is to administer surfactant in the small helical. We will show the technique in this video. We are using this Lisa catheter because it is easy to use and it is stiff, and there are less chances that spillage will be there or it will be kinked in the element. So we will rinse first the catheter, and we have rinsed it already. So we will insert this catheter. We have done measurement before that. This is the third LFA we are giving. Carbon dioxide detector is changing color as per it's showing in the video. So this is the last LFA we have to give. As we can see, baby has responded nicely to surfactant administration through this relatively new technique SARSA, which is surfactant administration through laryngeal supraglottic airway. Saturation has improved markedly and the heart rate is 150, and the baby is also very calm and very comfortable during this procedure. So we will attach with our CPAP.
These are my all Lisa babies. Some of them I put here. Thank you very much. And I'm happy to answer any questions.
Thank you so much, Dr. Monica. Really, it's amazing presentation. I'm sure that a lot of doctors have a lot of questions to you. We'll keep at the end the questions. Now we'll go for the second lecture, which is Lisa versus Insure by Mr. Alexei, our KZ Medical Scientific Manager. Mr. Alexei, the mic is yours.
Lillian, can we have questions now? Because I may have to leave, if you don't mind, for me.
Yes, why not?
Sorry for that.
If we can take 2 or 3 questions.
Yeah, please.
Yeah. So doctors, please feel free to ask questions in the, you can open your camera and you can open your mic and you can ask Dr. Monica direct.
Hi, Dr. Monica. Thank you for your presentation. I want to ask you, how much is the air bolus that you give after giving the surfactant?
So usually we are taking 1 to 2 ml only. 1 ml I'm taking, not more than that.
And do you give routine sedation analgesia during the procedure?
We were not doing it earlier. We have started doing it now. And
so you give, you give atropine routine, or if the patient developed bradycardia?
No, it's a routine, atropine and fentanyl.
Okay.
Yeah.
Good evening, Dr. Monica. Please, I have one question. Have you compared LISA with CPAP and LISA with NIPPV?
No, we have not compared, but we are for a smaller baby, we are putting the baby on NIPPV. So if a baby is less than 26 weeker, I'm not putting a baby on CPAP. I put the baby on NIPPV, and we are giving LISA through the NIPPV, and we have good results. Same.
Okay.
It has no difference. Yeah. But we are not compared. We don't have that many babies that we compare and, publish something.
I mean, any study compared CPAP versus NIPPV?
No, I don't think so. There are very few centers who are doing that, and I have not come across the study NIPPV and CPAP with LISA. I have not come across. Maybe I'll find out if there is any.
Okay, thank you.
I wonder if any more question. Dr. Monica is here. It's a good opportunity to ask questions. So please, if you have any question, please feel free.
Yeah, I mean, one question is that you should bring down the cost of LISA catheter so that more people can use it. Because, yeah, I had gone for a workshop, like I'm going nowadays because of this COVID, we are not going, but I was going to India, and we did this workshop of LISA, and then Dr. Ola had come from UK, and, he had brought his LISA catheter into, and then, the moment the people did this with LISA, it was so easy that, we were trying to do with the video laryngoscope, but then they said, oh, we don't need a video laryngoscope because it's much easier to use LISA catheter. That's for sure.
Thank you so much for your kind feedback.
Sorry, one more question, please. Any recommendation to increase flow of CPAP during LISA?
There are no studies to show that, but I'm sure it will come because of the sleek issues which have come up because of while you are doing LISA and the CPAP. And I wanted to highlight this issue because this is a new thing which is coming up, that you have leak. And I don't know if the leak can be prevented by increasing the flow or just by closing the mouth. Or by increasing the pressures. So because it might become very risky if you do any of the things when you don't know what's happening. So as per now, I would say that instead of doing that, just try to close the mouth so that you don't have a leak around the thing, till we get a good evidence that you can increase the flow to avoid the leak.
Okay, thank you.
So any more questions? And Dr. Monica, really, we appreciate today your lecture, and really it is very valuable to share your knowledge.
Thank you.
And personally, I learned a lot from you today. Thanks a lot for sharing this SARSA technique, which is new technique also. Thanks a lot. So now I will leave the mic to Mr. Alexei, our medical scientific manager, who will give more about the LISA catheter features. So Mr. Alexei, please, the mic is yours.
Yes, thank you. Lillian, I try to share my screen now. Please give me feedback if you actually see it.
Yes, start sharing.
Okay,
yes.
Great, excellent. So I put it in the presentation mode. Okay, great, excellent. Good evening. Assalamu alaikum. It's a great pleasure and privilege to be here with you today. My name is Alexey Shablakov, and I'm a medical manager in International Markets Development Division of Chiesi Company. Today, I will do a very brief recap regarding the use of LISA method, just to summarize with some more evidence and then provide more information about the characteristics of the LISA CAT, so the catheter specifically designed for the administration of Surfactant alpha cursor through the LISA method. And if needed, requested, I will share later on with you the slides or any content, any reference you could maybe require. This is my conflict of interest, my disclosure. So I'm a Chiesi employee. And so there are more important recommendations in the European guidelines regarding the RDS management. One of that is about LISA technique. So to consider nowadays LISA as a preferred method in spontaneously breathing babies. In the previous version of the guidelines published in 2016, and actually the European guidelines updated every 3 years, the LISA method that time was just one of the possible methods. But from 2016, more meta-analyses have been published. And so in 2019, it was decided to recommend it as a preferred method. That has been done because of more evidence, more meta-analyses that has been published from 2016 to 2019. And one of that is this meta-analysis of Isayama, in which the use of LISA was associated with lowest likelihood of the composite outcome of death and BPD at 36 weeks of gestational age. Another very nice research has been done by Rigo, in which this modality was associated with improved respiratory outcomes. It decreased early CPAP failure, mechanical ventilation, decreased the risk of BPD, and LISA also reduced the risk of composite outcome of BPD and death when compared with insured technique. And another very nice paper was done by Aldana Ger and colleagues, in which LISA reduced death and BPD and improved CPAP success by minimizing the need of mechanical ventilation. And with LISA, the risk of BPD or death is significantly reduced, with number needed to treat of just 15 administrations, and the rate of early CPAP failure was significantly reduced with NNT of 8. And in this slide, we see the recap of the main outcomes regarding the use of LISA in the meta-analysis of Isayama. So in orange, you see the statistically significant difference in favor of LISA, and in blue, not significant trend in favor of LISA. The same or quite similar results have been seen in Rigos and Aldana Ger analysis. And 1 year later, very similar data have been seen also in VU analysis, in which the studies were split in randomized clinical trials and observational studies, in which the results did not differ so much, as you can see in this table. And so if in 2016 there was no any preference recommendation for ensure LISA, both could be used for the surfactant administration. In 2019, European guidelines recommended LISA as a preferred method of surfactant administration in spontaneously breathing babies, provided, as Dr. Monica said before, by clinicians that are experienced with this technique and well trained on this technique. And LISA is not always successful. It can also fail, and baby should be intubated. And in 2019, Janssen and colleagues in Netherlands did a very interesting research in which they wanted to evaluate the incidence of LISA failure and identify the risk factors and assess the impact of LISA failure on neonatal outcomes. It was a retrospective cohort study, and they observed moderate LISA failure in concordance with the results of early studies, and they found out that the absence of antenatal corticosteroids and lower surfactant dose, so 100 microgram per kilo instead of 200 milligram per kilo, are risk factors for LISA failure that may be modifiable in order to improve the LISA success and the patient's outcomes. So with LISA, there are more advantages, as we could see in the previous slides, but it is important to have more comfortable and easy to use, efficient tool for this technique to facilitate its use. And to provide it, Chiesi, with the help of some neonatologists, delivered the LISA-CAT catheter only for oral endotracheal use, specific for the administration of Surfactant alpha, Curasur. We have on this, I will take the laser pointer. So we have the printed marks on it that provide a visual guide to the depth of the device insertion during the clinical use. So you can evaluate how much to insert, so 1 centimeter, 2 centimeters, 3 centimeters. In some previous publications, the insertion depth was advised to do based on the weight of the babies, but nowadays it's more about the gestational age, at least in Ventus guideline regarding the LISA technique use. Here, Vento and colleagues recommend to use 1.5 centimeters for babies that have less than 27 weeks of gestational age, and 2 centimeters if the babies have more than 27 weeks of gestational age. We have the standard lower connection to fit with the standard syringe, actually, so no differences. We have the reinforced shaft to provide the right resistance and suitable pushability. So you can see more layers to deliver that properties to the catheter. And at last, there is a rounded and soft tip. So the last centimeter that you can see here is soft compared with the rest of the catheter, and it's rounded to provide a non-traumatic lead for the catheter during the insertion in the mouth. And Dr. Monica actually talked about this risk during her presentation. So this is the description of the catheter. The working length is 13 centimeters. We have the outer diameter that is 1.7 millimeters, corresponding to 5 French. We have the internal diameter of 1.1 millimeter, corresponding to 3.5 French. We have from 5 to 10 centimeters for tip to lip measurement, and then 3 different rings marks that correspond to 1, 2, and 3 centimeters. And these marks are very useful to see what's the depth of insertion behind the vocal cords. And these 5, 6, 7, 8, 9 centimeters are very useful to see once you inserted the catheter, to see tip to lip how much is inside. So you can see through the laryngoscope or video laryngoscope if you have, and you can see afterwards even a tip to lip in the angle of the mouth, what is the insertion of the catheter. There are 2 relevant trials that support the use of rigid catheter and LISA-CAT for surfactant administration that I will not talk about, since actually Dr. Monica has already done it very well in her presentation. And we could learn from her presentation that more responders that used AngioCat and LisaCat preferred the LisaCat, and based on the questionnaire, we can see different characteristics of LisaCat or AngioCat and the preference. So in green, the preference for LisaCat, in yellow, no difference, no preference at all, and in red, the preference for the AngioCat. And the only exception is for lower, because it is the same in AngioCat and in LisaCat actually. More information regarding the LISA technique you can take from this very nice and comprehensive practical guide developed recently by Professor Vento, Bolin, Rohr, and Dargaville. I mentioned actually a couple of minutes ago about it, where you can find more information about the analgesia, sedation, infant position, equipment, training. So it's really has been done very well. And before I finish, I would like to share with you this very brief video. So it's just 3-4 minutes, which was developed with the University Hospital of Milan, the NICU of Professor Gianluca Lista, and supported by Chiesi. Oops. Okay, that was actually the last information that I wanted to share with you through that this very nice video that has been done in Milan. If you have any question, any curiosity about the device, I will be happy to answer your questions. And by the way, I noted a couple of questions that Dr. Allah done before, and if I can maybe add a couple of details about the answer, I would do it because Dr. Allah, if I'm not wrong, you asked about the evidence regarding LISA and CPAP alone comparison, right?
Yes.
Okay, because recently from UK was published a very nice research in which the UK neonatologists wanted to evaluate, to do this comparison, LISA, early risk administration through the LISA technique compared with CPAP alone. So no surfactant administration till the CPAP failure. And they not only wanted to evaluate the clinical outcomes, but more the economical advantages or disadvantages of this comparison. And so they have seen that not only clinical outcomes improve using the early rescue of LISA technique, surfactant administration, but even from economical point of view, it's more advantages, and there are some savings using the LISA technique in early rescue. And for early rescue, I mean the phi2 of 0.3. They used this strategy as actually is recommended by the European guidelines. If you want, I can share with you this very nice paper. If you provide them to my colleagues your email, I will share with you. And another question that you asked about is about the airway leaks and the recommendation even so in the guidelines, but in the video that we have seen together, is to close the mouth to avoid the air leaks during the continuous CPAP and so during the surfactant administration, the thin catheter. If any other question, or maybe request of material, presentation, references, I will be happy to support you and to help you.
Thank you so much, Alexei, for your nice presentation. Doctors, please feel free to ask Alexei any questions. You can open your mic and you can ask him directly.
Otherwise, even later on, if you have any doubt, any need, let know Lilian or Fadi, and they will put in touch with me, and I will be happy to put in touch with you actually.
Yes, exactly. I think now we are also in Thursday evening, so maybe all the people are exciting for the weekend. So thank you so much, Alexei, and thank you so much, Dr. Monica, for your nice presentations. I thank you all doctors and nurses who joined us today. Please, as Alexei said, if you have any question, you can email it to us. We can email it back to Alexei or Dr. Monica to answer your question. Thank you once again, and I wish you all a happy weekend. Thank you so much, and by now we'll end the session. Thank you so much.
Thank you very much.
Bye-bye.
Have a nice evening and enjoy the weekend.
Thank you. Take care.